We are South Devon and Torbay. We have 37 practices, we have 9 community hospitals and 1 acute hospital. And our biggest challenge that's facing us in terms of our population is it's increasingly ageing. We know that our projections are the number of patients over the age of 85 is going to increase phenomenally. So our challenge is how do we look after those patients, give them the most appropriate care to keep them in their own homes and manage those conditions without a need for unplanned admissions to hospital. The virtual ward is exactly that, it is virtual. It mimics a hospital ward, so you have a team of professionals who get together to use their multidisciplinary input to discuss the proactive care of patients.
There was some dispute about his target dose for his INR, the hospital.
We use something called the predictive model to come up with a risk score for patients based on other patients across Devon.
It is an adaptation of a basic model that was originally issued through the King's Fund. The main data sets that are used are GP practice systems, hospital attendance data and hospital admissions data. We also bring in certain other data sets that we found add some additional predictability to the model. So we get feeds, for example, from the ambulance service about non-conveyances, so patients where an ambulance has been called out to them.
The risk factors that they look at, the things that sort of we've found as indicators of likelihood of admission to hospital, are things like numbers of long-term conditions, numbers of medication. If someone's on lots and lots of different medication, that's often seen as a risk factor. How many times they've had contact with primary care, how many times they've had non-elective admissions to hospital, and how many times they've been in contact with the ambulance service. Practices receive that report once a month and they can see the relative risk scores of all their patients in a list. So we ask the practices to case manage the top 0.5% of their risk list. Those are the ones that are at the very top of the triangle, most likely to have a hospital admission within the next 12 months.
So we use the predictive model as part of our identification, but we also use some real-time data, because if you know that someone's in hospital and you know that's going to trigger a need for a lot of care and maybe repeated admissions in the future, then we try and look at that data. And we also try and use some local intelligence, especially where we think that it's not going to be included in the predictive model. And so that comes around at the moment in terms of mental health data and social services data.
The advantage of using the predictive model is it's getting them just at that little bit before they start to have those exacerbations that are going to start bringing them up. Lots of practices have said to us, okay, we had 20 patients and 17 of them we knew and we were already actively case managing, but there were 3 there we just didn't know about. So the patients that perhaps don't complain, the patients who sit at home and that they're not calling the GP, they don't want to make a fuss, they're not engaging with services for a number of reasons, they're being able to be picked up through their risk factors on that computer algorithm. So the virtual wards themselves, the practices hold monthly meetings in the practice and they bring in a multidisciplinary team. So you'd have the community teams, the therapists, the CPNs coming along. So really as many people as could help care for that patient holistically. Then what happens is those patients are briefly discussed. Each patient is then allocated a case manager who will then take that case further forward. In most cases it's the community matron. It could be someone from social care, it could be someone from palliative care. It's whoever is most likely to have the most contact with that patient during that particular month. The patient then gets admitted onto the virtual ward and then all these things are put in place. So the case manager is at the heart of it and the case manager will link with all these different agencies, making sure that we've got all those pathways clearly in place for those patients with very specialist needs.
Just for me in the surgery to catch a GP to talk about a patient, can be almost impossible. So to have that dedicated time when we're all in a room around one table, I don't lock the door, but almost as good as, and it really helps to keep the momentum going when you can discuss it in that multi-agency setting. This is about intensive support to put coordinated packages of care in place.
We've looked at the number of admissions that we've had. For the first 3 years we had the virtual ward. We then looked at the number of admissions for the top 0.5%, so the cohort of patients that are being managed on the virtual ward. And what we saw was that whilst the number of admissions rose slightly, the overall number of admissions. The number of admissions for that top 0.5%, the kind of patients we're managing on the virtual wards, actually reduced by 25% in the second year compared to the baseline year of year 1. And we're absolutely staggered by that. It doesn't mean that every single patient on the virtual ward has had that 25% fewer admissions, but it does mean that the cohort of a whole have come down. For South Devon alone, we knew that we could save about 365 admissions a year, so an admission a day. So you factor that up at the cost of an average cost of an unplanned admission for that kind of patient, and it is some quite significant costs. The reason that we've been successful, I think, is because we've worked at those relationships. You have to get that team of people round the table working together in a joined up fashion so that you don't have any barriers between referrals.
It's not just about reducing our emergency admissions, it's about making the experience better for the patient. What they should experience is one-to-one contact with one person, and it feels like their care and the services coming in are seamless and joined up. Now, we all know that they're not. You know, they're different services provided by different organisations, and that's the way health is, and voluntary sector and social services. But it's how it's perceived by the patient is what we're trying to change.